Good afternoon, everyone. I really appreciate people who came in late today, especially it's the end of the week. And I promise, people who showed up today will have a very good marks on the students' work. So you will be rewarded for coming at 2:30 on a Thursday. Don't worry about that. Today we're going to talk about patient assessment definitions. We talked last time about the importance of patient assessment. Anybody remembers why is it important to provide patient assessment? Why is it important? Why do we need to do patient assessment?
To do the right.
Exactly. Because half of the solution is knowing the problem. So patient assessment will help us identify the problem. Today we're going to talk about the basic definitions, and we're going to talk about acronyms. You know what acronyms mean? Usually American people, people in the United States use a lot of acronyms. So you go to a presentation in the United States, they don't tell you, for example, angiotensin converting enzyme, they say ACE. They don't say cardiovascular, they say CV. So exactly, those are the letters that stand for words or sentences. So that's basically what we need to learn about these acronyms in first aid. We need to know what are the different types of mechanisms of injury so we can assess better. And then we need to know about the initial assessment, the rapid trauma assessment, and the detailed physical examination. Let's start first with what we call scene size up. Anybody watches CSI? CSI New York, CSI Miami. What does CSI stand for? Crime, scene, investigation, right? So, the crime has a scene, and so the accident has a scene. You come to save a person or to provide first aid to a person, you are in a scene, you are in a theater, in a place, the place of the accident. So, first of all, you need to take note about what's going on. You want to look at the person, you want to look at what's around and make sure at first you see if you can provide safety to yourself as a paramedic, as a first aid provider, and to your patient. How do we do this? We do this by doing BSI precautions. This is a valid examination question. What is BSI? BSI means body substance isolation. Body substance isolation. What you do is you isolate yourself from the scene. You isolate yourself. If there are fumes, use a mask. If you are going to deal with your hands with the patient, you wear gloves. If you are going into a fire, you wear a fire-resistant jacket, right? So you do all your precautions so you can help yourself and not get into the problem. Part of the scene size up to see if any of the injured people will need advanced life support. What's advanced life support mean? دعم للحياة متطور متقدم. What does that mean? Does they need oxygen? Do they need oxygen? Do they need a pump for the heart? So we need to assess that too at the first glance. Then we start our initial assessment. What do we mean by initial assessment? We want to see if this person has any life-threatening problems. Is this person conscious? Is he aware of what's going on around him? Is he stable? His spine and his cervical area, are they stable? Airways, are they open or plugged? Is there any mucus? Is there any blood? Any dirt? So he cannot breathe. So we assess the breathing, and we assess the overall circulation of the body. We will do also a full impression about the patient. We check the patient. We try to palpate the patient. Do you remember palpation? Palpate. Just, so basically you push, feel is there any pain. You feel if there is any bruises. So you know if there's a trauma. You know what trauma means? Trauma, something. So if there's a trauma, so there is a bruise, you feel like there is nibera, there's like an extended thing. So you want to look at all this when you do your initial assessment. Everything is good right now? MashaAllah. Okay. Very important to stick to what we call golden hour. So within the hour, if this comes in the exam, what is the golden hour? What you would say, it's 1 hour that, or the time that's needed to make sure that this person does not go any irreversible situations. So when I make sure that this person does not go into full disability, any problem that I cannot solve later. So I want to stop the progress of any problems. Out of this golden hours, there is the platinum 10 minutes. They are not golden, they are even platinum. Why they are platinum? Because within this 10 minutes, you have 1 minute to do your assessment, 1 minute. You have 5 minutes to do the stabilization of the patient, and then you have 4 minutes to transfer this patient to the nearest hospital. So those are the 10 minutes, the platinum 10 minutes. We may, if this person is conscious and we can communicate with the person, we need to see if we can do focused history and physical examination. What do we mean by patient history? From clinical pharmacy, from other classes you know about clinical pharmacy.
Disease history, drug history.
Drug history, disease history. There's one that we always miss. Do you remember what it is? Social history. It's very important. Because social history tells you what kind of job he does. Is he a smoker? Does he have any bad habits that I need to include in my assessment? So that's very important. And then I can determine whether I need to do a rapid trauma assessment or a focused assessment. Because rapid trauma assessment when there is a trauma. If there is no trauma, I will go to focused assessment. There's a way of dealing with history. We call this the sample history. Sample is an acronym. So S stands for a word, A stands for a word, M, L, P, L, E. Let's see what these words stand for. S stands for signs and symptoms. What's the difference between signs and symptoms? شو الفرق بين الساينز وبين السيمبتومز؟ Patient tells you the symptoms. Signs, you look for signs. Symptoms, I'm متوجع, ما عم شوف. That's symptoms. Signs, there is yellow in his eye. There's yellow, it's yellowish. It's pale, his face is pale. So these are signs. We look for allergies. We did a research over the last semester trying to see the use of antibiotics in Al-Medina. So we went to a lot of pharmacies, a lot of community pharmacies, and we were surprised. None of the pharmacies asked for allergies.
No.
Nobody asked you what kind of allergies do you have. So you need to know the allergies because you can give the patient something that might kill him or kill her. True? So allergies is very important. Past medical history. What do I study in past medical history? What do I ask for?
The reference medical case.
Reference medical situations, yeah, cases. What cases that this person went through? And did they have any diseases and surgeries, operations? That's right. This is very important when I ask for the past medical history. Medicines or medications, I need to ask what kind of medications so I can prevent any drug-drug interactions or drug-disease interactions. What's the last oral intake for this person? When was the last time they could have something through their mouth? And for ladies, it's the menstruation. When was the last menstruation? Events that led to the injury. What happened? I was walking around the block. I felt tightness in my chest. I was playing tennis when I couldn't breathe, when I felt heavy breathing. So all of these are what we call the sample history examination. Now, because signs are usually more for physicians, we have what we call the ample test. we don't look for signs and symptoms, more we start talking about allergies, medication passed. And that's after initial assessment. Another thing, when we look at history, we look at OPQRST. OPQRST, consecutive letters, and they stand for different things. They are actually part of the sample history, but they focus on the sign and symptoms and look for their onset, look what provoked it, what made it happen, what made it worse, what made it better, look for the quality of the sign or the symptom, look for the radiation, is it in one place or is it radiating, is it traveling, look for T for the time, and S, look for the symptom itself. So the onset, what do you mean by the onset?
When it start?
When did it start? What were you doing when this thing happened? I was like Ted. Do you see Ted on Fox?
No.
You don't watch TV? Okay, good. That's good for you. But he started having his headache while he was having breakfast. So that's the onset. He got his chest pain when he was mowing the lawn, doing hard work. So that's when that started. That's the onset. What provoked it? What makes it worse? What makes it better? Okay, is there anything that makes this better? Yes, if I sit down, my heart gets less tight. But if I lie on my back, I cannot breathe. SOP is shortness of breath. So I cannot breathe. I have more difficulty breathing lying on my back rather on my side. Okay. Quality. You need to ask, what is the type of pain you have? Can you describe the pain? Oh, the pain is like you are stamping a dragger. كأنك عم تأخذ خنجر في خاصرتي. هذا هو البين بالعكس. Another thing, like you are sewing. كأنه منشار عم ينشر برقبتي. طيب, like an elephant crushed me. كأنه فيل ومعسني. هذا نوع الألم. People have different ways of describing their pain, right? And then from this description, you can tell what could cause that pain. Another thing is, I said the radiation. So is this pain only in the knee, or is it moving, radiating? Usually radiating pain is more related to the bones and nerves, because nerves are the ones that transfer the pain. So this person, for example, we all know him, right? Yeah. When he fell on his knee, he's not only his knee, it's partly radiating to his pelvis too, right? So it's moving. Severity of the pain. You remember from last time when we gathered the information, we had two types of information, subjective and objective. And we said that with subjective pain, we cannot really measure them. So we need to find a scale to measure subjective, to measure the patient's agony, patient's bad experience. So for example, for pain, we tell them on a scale from 0 to 10, how is your pain? When they first come to you, they say, oh, it's terrible. 10, 10. Okay, take this painkiller. How is it now? Oh, it's 8, it's 5, it's 6. So now you can tell if your treatment is working, and you can measure the severity of the symptom. Time. Time is always of an essence. What is the duration of the symptoms? How long have you had this chest tightness? How long have you had this headache for? You need to know. Because once you know this, you can tell that this is a persistent, that this is transient, that this will go on its own. Rapid trauma assessment. When I ask you rapid trauma assessment, I will ask you what are the elements of the rapid trauma assessment. It's A for airway, B for breathing, C for circulation, D for disability, E for examine, F for Fahrenheit, G get vitals, head to toe for H, and intervene or intervention for I. What's the difference between airway and breathing? Airway. What do we look when we are doing our trauma assessment? You know what trauma means, right? شيء صدمه لهذا الإنسان. crash. انضرب بالسيارة. وقع. خبط. طيب. أول شيء you look at the airways. So when you look at the airways, you look if they are plugged. مسدودة. So you open them up. You look in it. See if there's any dust, any blood, any mucus. Try to suck it out, take it out. Breathing. The airway could be open, but the person cannot be able to breathe, right? Problem with the muscles. Problem with the circulation. He cannot breathe. Sometimes you come to the scene and you see someone's doing في واحد بقى بيصير على البصر شو بك؟ like شو بك؟ What does that mean? He wants air. He can't breathe, right? So you need to look at this person. Circulation. How can you tell if the circulation is right or wrong? If it's okay or not? Color of the skin, of the body.
Blood pressure.
The blood, the pulse. Is the pulse strong or weak? That's all can tell about the circulation. Disability. Can he move? Cannot he move? Examine. What do you examine? Everything. From head to toe. Look in the eye. Push here. You look for trauma. Is there any bruises here? Any pain? Once there is a pain, you stop, right? Because you know that there is an injury in this area. You look for Fahrenheit, which basically you look for temperature. Is this temperature down because of lack of circulation? That's another way of looking at the circulation. The temperature is down for this person. Vitals, pulse, blood pressure, eye. So you do a head to toe, and then you decide what's the best intervention. What is the best you can do for this person? How you can add to this person. Let's take a look at this video. Let me see 1 second. I'll just turn the sound up. Just listen carefully. This is how we do the trauma. And it's available, you can actually, it's on YouTube as well.
What I'd like to go over with you right now is scene assessment, initial assessment, and a rapid trauma assessment for a trauma patient. So as I'm approaching my scene, I'm going to be given a dispatch information, probably anticipating the trauma patient. I want to reconfirm that it is a trauma patient, that if I need additional resources, given that I want to assess how many patients there is and how many what resources I'm going to need to manage that patient. And also I'm going to approach the patient, I'm going to delegate C-spine to trained set of hands to hold the head still. So we'll use my imaginary partner for the moment to have my patient hold it to maintain their C-spine organization. And remind myself that I should have personal protective equipment as I approach the patient. So as I approach the patient, I'm wanting to assess skin color and level of consciousness to have a general understanding of where my patient is as far as blood pressure and level of consciousness. So we approach, let's say my patient is not responsive and they're pink and they're breathing fast. So as we approach, I'm going to confirm a level of consciousness. I'm going to say, hello, sir. We'll say that no response to verbal, it's painful, or sternum rub to assess if they're alert to painful stimuli. Let's say he's not. Then I'm going to turn my attention to the airway very carefully and actually look in the airway, open in the airway. If I see any secretions in the back of the airway, blood, vomit, or secretions, I'll suction that out. I'll make notes that my patient's not protecting their airway at that point. And then I'll delegate another set of hands to give me an OPA, or I'll turn around and grab that myself. Once the OPA is in, and then I'm going to turn my attention to breathing. I'll put my hand on the patient's abdomen and assess and count to 5 seconds to make sure I have an adequate respiratory rate and adequate depth. So I'm going 1,000, 2, 1,000, 3, 1,000, 4, 1,000, 5, 1,000. If I have a breath in that duration, then it's an adequate rate at a minimum. And assessing depth, if I have an adequate depth there, and my question that I'm trying to answer there is, do I need to place it, to ventilate this patient with bag valve mask. So we'll say that he's breathing adequately at this time. We'll get 100% oxygen on the patient at this time. Then I'll turn my attention to pulse, and I'll feel pulse. I'm just looking for, is the pulse present, and is it being effective, and am I feeling a nice strong pulse? So as I'm counting, I'll count just 1/1000. I'll count for each second. Do I have at least a beat? And if I have greater than 2 beats per second, then I'll...
1 beat per second at least.
Thinking in a trauma patient of hypovolemia, but also want a good cardiac monitor on them sooner to be able to evaluate them continually. So let's say I have a radial and carotid pulse that's less than 120 beats per minute. Then I'll turn my attention to the patient's head, and I'll assess their head, palpating all bones, pushing in on their
head to toe
all
assessment.
surfaces, feeling to find if there's any evidence of trauma indoors. Also, I'll look in my patient's pupils and see if they're assessing for if they're pural. To the neck, I'll look for any evidence of trauma, and then I'll assess to see if the trach is midline, see if there's any jugular vein distension. Down to my patient's chest, I will expose every region as I go before I palpate it. Expose, look for any evidence of trauma, then I'm going to push firmly. I push firmly in clavicles, around the sides of the ribs, and right down the center of the sternum, making sure everything's nice and stable. I'm not feeling any crevitus or instability. Then I will auscultate ×4, just looking for gross adventitious breath sounds and air, whether or not we're getting good air entry, to learn whether or not we should be ventilating this patient. So auscultate ×4, inspiration and expiration, inspiration and expiration, inspiration and expiration. Now into the belly, I will expose, look for any evidence of trauma, I'm going to palpate ×4, looking for distension and rigidity, and grimacing as a result of pain, from pain caused by me palpating on this patient's abdomen. Then I will actually assess pelvis, I'll expose, look and see if my patient's incontinent. Then I will push down with an increasing pressure, and then push in with an increasing pressure, not jerky motion, just a steady pressure down. If you feel any movement or cause the patient any pain, we'll stop and then we'll bind that pelvis. We'll treat that with a high degree of suspicion for a partial pelvis. Then down femurs, we'll palpate femurs either way. Knees, we'll see the knees are intact. Lower extremities, down to feet, we'll have a look for color, movement, and sensation. We'll just be looking for cap refill real quickly in ankles if they're shoes. If they're don't have shoes, we'll look at toes just to see do we have peripheral circulation and how strong is it. Then working our way down arms, compare each side, compare joints, lower arms, looking for any evidence of trauma. If they were conscious, I would get them to squeeze my hands and I push down with their feet, but this patient is not. So I'll check cap refill, compare radial pulses. Now I'm going to get my patient onto a backboard. Given that he's unresponsive, we'll get in the truck as soon as possible and limit treatment as much as possible to backboarding. We'll only manage airway, breathing with bag valve masks, airway with suction, and OPA. Circulation, we'll stop deadly bleeds, and in the chest, if there's a flail chest, we'll splint it. We'll also turn attention, if we have tension pneumothorax or the ALS, we would address that as a breathing problem. The pelvis, we would splint pelvis as splint long bones, but all of that with a real focus of getting off the scene and getting to definitive care as a surgeon. So that's rapid trauma, that's our initial assessment, scene assessment, initial assessment, and rapid trauma assessment.
All right, so basically we've seen what we do when we come to the scene and how we can deal with the patient. This is basically all the steps are being demonstrated to. There is also a rapid medical assessment, and that's what actually we perform when this person is unconscious. We're not able to communicate with the person. Or this person is actually cannot really tell what their problem. They cannot really tell you what their chief complaint. So that's what when we use the rapid medical assessment. and we've seen a quick one too. The other video you can actually watch at home. It's basically a communication between the same paramedic and the patient and the kind of questions that need to be asked. Another thing that we do less often is basically focused history and physical exam. We do this when we cannot really tell from the scene up, we cannot tell about the mechanism of injury, and this person is not really in a critical situation, so we need to make sure that everything is fine, so we go more into details with this person about any possible fractures or any possible unseen or unnoticed injuries. The focused history and medical exam in the medical, this is when we talk to the person, we have the opportunity to actually check their sample history, and we can tell about the signs and symptoms and try to assess all the severity, the onset, and different things about the signs and symptoms. Remember, what are the tools for physical assessments? We had it, I think, in the 4th level. So it's basically inspection, palpation, percussion. You know what's percussion?
Sound.
You see the sound of different areas in the body, and that can tell you a lot about the injury. And then you can oscillate, you can listen through the otoscope. Detailed physical examination, usually this is done by the physician, and that's go through all the details about the patient history, different kinds of history taking, making an assessment, and provide a plan and a follow-up plan to this person. Ongoing assessment. So many times we look at ongoing assessment as something that it's a follow-up after the injury. No, ongoing assessment in first aid is basically what's happening, the assessment while we are moving this person as soon as possible from the scene of the accident or the injury to the hospital. So if this person is critical, we do it every 5 minutes. If this person is stable, we do it every 15 minutes. And that's basically the kind of questions we ask ourselves. Is the treatment improving the situation? Is there a problem? Is the problems getting worse or better? And what kind of problems that were initiated from providing this treatment? The second section of this talk today is going to be about the acronyms. So we're going to learn about the acronym. So the first one is MOI. What does MOI stand for? Mechanism of injury. And the mechanism of injury, how does this injury happen? Then we have the AVPU, and that's basically a scale to measure the consciousness of the person. So A stands for awake, or alert and oriented. And what's the difference between alert, awake, and oriented? What are the differences between the three words? Awake, shani awake. صاحي ما نايم. Alert. Alert يعني إذا واحد ناداله بيديروا الشغل لما كان الصوت. And oriented, he knows what's going on around. He knows. V is only alert to voice, but has no orientation, no sense of orientation. P, only responsive to pain. So when we, like the paramedic did, when we initiate pain, that's when the patient responses. So this person is alert to pain, or unresponsive at all. This person, even to pain, is not responsive. Another thing that we need to assess also is the CUPS. C stands for critical, U for unstable, P potentially unstable, and S is stable. So in critical situation, person is required, the patient is required CPR. Is usually unconscious, cannot breathe, has ventilation problem, or a circulation needs circulation support. Unstable means it's getting worse by time. So basically, this person cannot respond to refluxes. He cannot actually, if you put water in their mouth, they don't gag, shut up. So that's nothing. Potentially unstable, responsive but unable to follow command. Like he responses to gags, but if you tell him to do something, this person cannot do it or will not do it. There are like too many examples here are mentioned about potentially unstable. Stable, that means the person has got to the place and they will not get any worse. So those patients usually can wait. Okay. Different types of mechanisms of injury also. Vehicle pedestrian collision, death in the same passenger compartment, high-speed accidents, medium speeds when children actually get into trauma because of a minor accident, fall greater than 20 feet, the person gets ejected out of the car, or the child falls over a bicycle, and there is actually a penetration. Something goes into this person's head, body, arm, etc. Okay, now we're gonna practice this. So the practice session will actually, you can stop the